Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the pleasure of welcoming back my dear friend and colleague, Professor Alessandro Santin, from the Yale School of Medicine in New Haven, Connecticut. We're going to be talking about the February lead article titled Folate Receptor Alpha as a Successful Biomarker in the Treatment of Low-Grade Serous Ovarian Cancer Patients Using Preclinical and Clinical Models. Alessandro, thank you so much for accepting our invitation. Thank you for submitting this article to our journal. Really looking forward to discussing this novel concept and the details of this manuscript. So, welcome to the podcast.
Thank you, Pedro. It's always a pleasure to have this podcast.
Excellent. So, Alessandro, we have lots of questions. I wanted to start by discussing the topic at hand. If you can tell us about low-grade serous ovarian cancer, why do we need novel therapies in this disease?
Sure. So, as you know, low-grade serous ovarian cancer is a rare tumor. Only 5 to 10% of the over 21,000 diagnoses of ovarian cancer in the US are low-grade serous. So they are relatively rare, but they have distinct molecular and clinical characteristic from the high-grade serous that we diagnose, of course, much more frequently. And when I say different molecular characteristic is because, for example, P53, that is one of the main characteristics of high-grade serous, so the mutation in P53, is not really present in this tumor. Usually P53 is wild type. About 1/3 of this tumor, they harbor KRAS mutation, and another, I would say, 1/3 of low-grade serous have other mutation in the MEK pathway. That is usually what we are currently targeting in the clinic. The real issue with low-grade serous is that they are really much more resistant to chemotherapy when compared to high-grade serous ovarian cancer. And this, of course, is a problem because they are relatively indolent tumors. So these patients are usually younger when you diagnose them with ovarian cancer. They survive longer. But this type of cancer, because most likely this low growth, is much more resistant to adjuvant chemotherapy treatment. So we need to look in new direction, more effective direction, less toxic direction. As you know, what we are currently using, because we always try the chemo, but it does not really work well, are hormonal treatment, so aromatase inhibitor in particular, sometimes progesterone, as well as a MEK inhibitor, because as we just discussed, about 1/3 of this tumor harbor KRAS mutation, another 1/3 has anyway other gene part of the MEK pathway that are altered, so about 2/3. And therefore, the MEK inhibitor have recently, I would say, demonstrated activity, but unfortunately, they're also significantly toxic. I mean, as you know, over 1/3 of patients usually stop treatment because of the toxicity. So we need new tools in our armamentarium that can be effective and better tolerated.
Excellent. So a perfect segue to my next question. You mentioned obviously about the low response rates with chemotherapy, how we have often used hormonal therapy. And as you said, now we have the option of MEK inhibitors as well. You talked a little bit about the side effects. What are the latest updates in terms of the data supporting the use of MEK inhibitors and how efficacious are these agents?
Yeah, so I think that a major advancement in the treatment of recurrent, in particular low-grade serous ovarian cancer, is the recent approval, I believe was May last year, of a combination of avutometinib, that is a RAF and MEK inhibitor, with defactinib, that is a focal adhesion kinase inhibitor that block the FAK pathway that get usually reactivated when you're treating patient with MEK inhibitor. So this combination has been shown to be effective with a response rate of 42% in the KRAS mutated low-grade ovarian cancer, previously treated with chemotherapy, and now with recurrence and progression, and also shown some activity in tumor that they did not harbor KRAS mutation, around 70%. So this is, I would say, that is now the new standard of care for patients with low-grade serous ovarian cancer that have been exposed to chemotherapy or previous treatment, hormonal treatment, they fail. And now we have this combination treatment. I can tell you that personally, I was one of, I believe that the top enroller in the US in the RAM 201 trial that has been used by the FDA to approve this drug. And I can tell you that this combination of the avutometinib, twice a week, 3 weeks on, 1 week off, and the focal adhesion kinase inhibitor, twice a day, 3 weeks on, 1 week off, was relatively well tolerated. I had very few patients that were had to do dose reduction or stop treatment. So I would say probably only 1 out of 10% of the patient have to stop it for toxicity versus the 30% of the other type of MEK inhibitor currently available to treat these patients. So I think major advancement with this combination since last year.
Yeah, so I definitely agree. Of course, obviously, many options for our patients now as it pertains to that targeted therapy, but we're not there yet. And can you tell us now a little bit more as we get into the details of this manuscript about the folate receptor alpha expression, mirvetuximab? How do these play a role in low-grade ovarian cancer?
Sure, sure. Yeah, so we discussed this new treatment in low grade, but of course, and we just discussed, we see a good response rate, prolonged disease-free survival, but majority of these patients, unfortunately, eventually develop resistance. So we need, for sure, other treatment that can be effective in this setting. So that is one of the reasons why, again, we are discussing this paper, a case report with some basic and translational work, because specifically one of my patients treated previously with a combination that eventually progressed. And at that time point, as you know, we are really short of option. So we tested the folic acid receptor expression on the tumor of this patient, and we found a very high expression, 2 plus 3 plus 85%. And so therefore, the next step was for us to say, okay, is this a single patient or we can broaden this type of result on a larger patient population? So that is why we went back to look to about 27 cases that were available in our tissue bank at Yale. And we found that the overwhelming majority of these tumors, they were indeed expressing a high level folic acid receptor 2 plus 3 plus. So that was, of course, surprising because there is, as you know, scant literature, at least up to now, in terms of looking to the expression of folic acid receptor in low-grade serous ovarian cancer. But we were, again, surprised in a good way. And we know now that not only high-grade ovarian cancer, but also low-grade may overexpress folic acid receptor. And even with the limitation that we're going to discuss today of a single case report, I think this was really some sort of proof of principle that when you are properly selecting the patient and the target is expressed, like in this case, you may obtain, I would say, a prolonged type of clinical response also in patients with low-grade serous ovarian cancer, as long as they express the folic acid receptor high level.
Yeah, and certainly definitely caught the attention of reviewers and for us as well. Obviously the innovative component of looking to explore this in this particular patient population. So you talked about the study and the methodology. Tell us a little bit more about the results. What are some of the things you would like to highlight, not just about this patient, but overall as you were going through these findings?
Sure. So I think that in terms of methodology in this paper, we have used a standardized test validated in the molecular pathology department at Yale University for the research component that are these 27 cases of low-grade serous ovarian cancer we had available. Um, and we have used all slides to do the staining. That, in my opinion, is always the best way to approach it when you're trying to do immunohistochemistry because you're really staining a significant amount of the disease, right? And that, of course, allow us to get this type of result that are a little bit higher when we compare to the literature, compared to other again, peer review report published looking to folic acid receptor. But majority of other studies, they use tissue microarray. And as you know, tissue microarray, they use a small core, usually are 2 millimeter type of histologic core from the tumor. And when you are dealing with heterogeneous tumor, and now we know that ovarian as well as uterine cancer are heterogeneous tumor when we're talking about different biomarker expression. HER2 is an example. I think that the old section is the way to go, and that is why we really selected this strategy to test for the expression. Now, again, we've used a validated test, not FDA approved for the research component, and they use reagent different from the Ventana test that we've used to validate the expression of folic acid in the tumor of the patient that we treated with Mirvetuximab in the case report. But that was the approach that we have used. So, and I trust both data because, again, they've been validated internally as well as, of course, externally at Ventana.
So now, the first question from one of our fellows, Joanne Nouveau, she's from St. John's, Newfoundland, and she's asking about real world practice. And you already were alluding to the type of testing. Her question is, you chose whole section immunohistochemistry rather than tissue microarrays and did not use the FDA approved Ventana assays. Decisions that matter in a biologically heterogeneous tumor like low-grade ovarian cancer. So can you explain why whole section analysis was critical, how assay choice may over or underestimate the folate receptor expression? And truly to her question, how should physicians interpret folate receptor testing in real world practice?
Sure. So, all section, as we discussed a minute ago, I believe is what we're doing, in clinical practice. And this is really to be able to identify the heterogeneity in the expression of in this case, folic receptor, as well as other biomarker that we're, of course, looking into in terms of expression. So the whole section is the way to approach the testing. Having said that, again, there are, of course, other variables. The monoclonal antibody that we're using that recognize different epitope, different folic acid receptor epitope, and therefore may have a stronger or lower avidity for the target, and that may explain a discrepancy in result between study. And the other thing is that I remind you, this was a retrospective analysis of our data, of our cases at Yale. There was no funding for this type of report. So that is why in a situation like this, the research type of test is usually the only possibility, because otherwise to run to Ventana all these 27K would cost a fortune that we couldn't really do. But for when you have clinical implication, like in our case, the patient tumor that at the end we decided to treat with Mirvetuximab was tested with the FDA-approved Ventana test that is run in our own molecular pathology department. Because again, here I'm lucky enough to work in an academic institution that a few months after the approval 2 years ago of the Ventana testing for the selection of patient eligible for Mirvetuximab treatment was able to quickly validate that test in-house. So talking about the real world type of evidence, and again, each practice is different. Here, for me, it's relatively easy because in, I would say, 72 hours from my request of the Ventana report of the validated test, the Yale clinical validated test, I have the result for my patient, as long as the tissue is in-house. So I think that can be done, of course, but there are different practices. Of course, they may have different issues in terms of turnaround time and also skill of the pathologists that perform the testing.
Excellent. Alessandro, this next question is from Mo Byrne. She's at Memorial Sloan Kettering in New York. She's asking about the time points of testing. Her question is, another study demonstrated discordant results in primary and recurrent low-grade tumor samples with regards to folate receptor positivity. Has your team looked at samples from different time points in these patients, particularly those who initially tested low expression?
The straight answer, Pedro, is that not. We have not done that type yet. What I can tell you, in the 27 cases that we were able to retrieve, I believe the majority were primary with a small subset of recurrences. We did not see, again, major differences, but the number are small, so it's difficult to draw conclusion. I think that it's going to be interesting and important to see if the exposure to chemotherapy, hormonal treatment, or other ADC may somehow affect the expression of folic acid receptor in the recurrent setting, but I don't have that answer yet.
Yeah. Another question from Mo Byrne. She's asking, the number of patients with positive results in this study is higher than those reported previously. Why do you think that is?
I think that is as we alluded before, that our study has used different monoclonal antibody targeting folic acid receptor, and as use, of course, all section. So we have the possibility when you're using all section to do to 1.5 square centimeter of tissue. That is much more than, as we discussed, the 2 millimeter of the tissue microarray type of report that been published in the literature. So I believe that these are the major things that may explain the difference. Consider the heterogeneity and the fact that we have used different monoclonal antibody compared to other studies. If I may add also, the Ventana testing is much more stringent. So usually, again, the Ventana, so we overestimate, let me put it this way, when you're using the research type of testing, our result compared to the FDA-approved Ventana testing. So that is something to keep in mind.
Yeah. Next question comes from Italy, in Milan, Carlotta Sabini, and she's asking, in your study, mirvetuximab is administered to a heavily pretreated low-grade ovarian cancer population patient after chemotherapy, hormonal therapy, and MEK inhibitors. Since your report a high rate of folate receptor positivity in low grade, and given that mirvetuximab is already being explored in earlier line combinations in high-grade serous ovarian cancer, do you think there's a rationale for investigating folate receptor targeted antibody-drug conjugates earlier in the treatment of patients with low-grade ovarian cancer?
Yeah, this is a good question. And I think that no doubt with the poor response that we see with standard chemotherapy treatment, as we discussed before, we need to investigate new treatment approaches for the disease. Um, Mirvetuximab is an antibody-drug conjugate. And so even if the molecule itself, of course, is able to somehow provide within its cargo the toxic payload to tumor cell, does that in a different way compared to standard chemotherapy. Because usually here there is an internalization of the antibody-drug conjugate uh, through the endocytosis of the receptor from the surface of the tumor. So we may be able, if you were, that what I'm trying to say, to see much more activity, even in a relatively indolent and slow-growing tumor, when we are using ADC as a way, as a strategy to administer, chemotherapy to this patient. So that is why I believe that the possibility for mirvetuximab to demonstrate much more activity than standard chemotherapy exists. So that is why we really should do the study to try to really validate the activity in a clinical trial.
Yeah. This next question comes from Paula Mateo here at Houston Methodist, and she's asking, why did you choose a 50-day follow-up period? What was the rationale for that specific time point duration?
50-day, not sure about this question because remember, this is a retrospective type of analysis of a patient treated on a compassionate basis with mirvetuximab. So I believe she's referring probably to the CAT scan between baseline and during treatment. This was not even a local patient. This is a patient not from Connecticut. So we started the treatment at Yale, but she went back, I believe, to Virginia to receive treatment. So there was some difficulties, of course, and again, this is retrospective. So we did the baseline, usually 2 to 3 months later, we were requesting a CAT scan, but we had to accommodate the schedule of the patient. So I think that explains why we had this type
Makes
of.
sense. Yeah. This next question is from Masha Pervin, University Hospital of Münster in Germany. And she's asking, what do you think might factor into the complete response for the patient on mirvetuximab as opposed to the mice reaching stable disease and not complete response, even though the tumor graft came from that same patient?
Yeah, so clinically, the patient responded with a prolonged partial response. And I think that in the case report that was, again, submitted several months ago, we had up to 8 month follow-up. We are now to 12 months. Actually, I saw the CAT scan of this patient last week, and he's still showing a confirmed PR after 1 year. So I'm very happy about that patient. She's doing very well on treatment. So this is a prolonged, again, partial response. In the animals, so the PDX was treated for 3 weeks and twice a week for 3 weeks. And this is really for reason that we had to acquire the mirvetuximab, so we couldn't really keep on going forever. And at that time point, after 3 weeks, there was already a major difference between our control mice versus the one treated with mirvetuximab. So in the animal model, we had seen a good activity of the mirvetuximab because there was for sure a prolonged cytostatic effect of the agent. The disease did not disappear, but did not grow for quite a long time. So I think that there was no discrepancy here. The response was similar in both models.
And now on to a related question as well. This one back from Paula Mateo. She's asking, given that all xenograft mice came from one patient, how confident can we be in generalizing these findings to other patients with low-grade serous ovarian cancer?
So this is a good question. And of course, this is a case report. So again, as we discussed before, I believe that the bottom line is that we now have proof of principle that with the proper selection of the patient, as long as the tumor, low grade, overexpress folic acid receptor, we may see clinical responses. I can tell you off record that I have a second patient that I'm currently on Mirvetuximab, and she's been on mirvetuximab now for 10 months with a prolonged stabilization of her disease. Not a partial response, but her CA-125 dropped from, I believe, 340 to 140, and that's really stable for 10 months. She's doing also very well. So we need more cases. We need a trial, no doubt about it, to generalize to the entire patient population. But when you have a very limited option, in particular in the recurrent setting, when the disease becomes resistant to aromatase inhibitor, MEK inhibitor, does not respond to chemo, we need new agent. And I believe that to do the testing is easy. And remember, Mirvetuximab FDA approval is broad spectrum. They don't limit to the high-grade platinum-resistant ovarian cancer patient. So you should not have major issue if you have a patient like mine and you are able to demonstrate overexpression to get approved the Mirvetuximab for even for a low-grade platinum-resistant patient. So keep this in mind. Again, yeah, I think it's a potential option.
Excellent. Matilda Dell from Toulouse, France. She's asking about, do you need a new biopsy at the time of recurrence, or can folate receptor alpha assessment be anticipated to be the same using the primary surgical specimen?
This is also a good question. Again, to be able to properly answer this question, I should have matched sample, right, collected before and after treatment that I did not have in these 27 cases that I have reported in the paper. So I cannot really answer that question, unfortunately, at this time point, but I'll say completely. What I would anyway recommend is to test the tumor. If you don't have the recurrence tumor available, test very simple. Because again, we don't usually go back to do surgery in this patient. So, and quite often as a GYN oncologist, and Pedro can, I'm sure, confirm that, even a biopsy is not feasible quite often because you have a miliary type of spreading, but you don't have big masses that can be easily biopsied safely in the abdomen. So I would say use what you have available, and if the expression allow you, treat the patient.
Yeah. Another question from Matilda, not specifically about low grade, but she wants to know about your daily practice with mirvetuximab. And she's asking, given the ocular toxicities, are there any strategies you identify that can help you determine who is at a higher risk or to prevent these events of ocular toxicity? And can this even be explored in mouse models?
Sure. So I would say that in terms of the identification of patient that are higher risk to develop eye toxicity, yes, I think that again, as you know, is over 2 years now. I think mirvetuximab has been approved, and I've been using mirvetuximab before to 5 years in clinical trial. So we already know that patient with, for instance, they already have cataract before starting mirvetuximab, or that they have any sort of glaucoma or corneal scarring, are going to be a higher risk to develop eye toxicity. And that is something that, of course, now we know because before starting patient on mirvetuximab, is some sort of mandatory to have an ophthalmology type of ocular evaluation of your patient. At that time point, you have to take the decision, okay? Meaning that if the patient has a cataract, you're going to tell her this cataract most likely can get worse. But at the same time, you also have a patient that has a recurrent ovarian cancer in progression. So you have to really discuss cost and benefit. And I can tell you that personally, I had several patients that I started on Mirvetuximab. I was able to put either in remission or at least in control the disease. And at that time point, they had a cataract surgery. And after went back on treatment. So again, you may identify this patient at the end of the story, depending on what type of eye problem they have. You're going to recommend yes or no the use of mirvetuximab, but remember also what are we dealing with, right? These are unfortunately lethal cancer when they come back, and then that is why you need to really discuss cost and benefit. Um, Regarding the animal model, I think it's going to be difficult here because um, the pathogenesis of corneal toxicity, even if it's a ADC class effect, we are seeing it in a lot of antibody-drug conjugate, not only mirvetuximab, is not really completely clear. So to mimic or reproduce this is in an animal model, I think is going to be difficult.
Yeah. Going back to Italy, this question comes from Tommaso Meschini, University of Insubria. He's asking, given the central role of MAP kinase pathway alterations in low-grade serous ovarian cancer, did you evaluate whether these alterations were associated with folate receptor alpha expression levels in your cohort?
The straight answer is we have not done that type of analysis yet, but it's for sure something that we are considering. To be able to do that, we must do all exome sequencing on all these tumors, right? Because we need to really know not only about KRAS, that the majority of commercially available platforms are able to detect and report, but also other genes that are part of the MAC pathway. So that is why, again, I think it's a good idea, but we need some support to do that, and we're into that because all exome sequence is still relatively expensive. Yeah.
Yeah. Last two questions from our fellows. They come from Zaniru Marin in Mexico. And the first one is from the practical standpoint, are there any women that are more likely to benefit from this targeted approach in this particular setting?
So this is a good question. So I would say that the expression level of the target, in this case, folate receptor, is of course very, very important because these are targeted agents. The target must be expressed. Now, as we discussed before, the expression can be heterogeneous. So that is why you really need to look to the all section so that you don't consider false negative a potential candidate to this treatment. And we have seen that with the HER2 new targeted treatment in the past. I mean, so you have to, again, properly select the patient. And the other thing that we also touched on before is when potentially recommend this treatment. I think that knowing that the chemotherapy has such a low response rate in this patient, I would say that in the near future, when you have filled the standard, and as a standard now, I consider the oral avutametinib and the defactinib inhibitor and the aromatase inhibitor. I think that as long as the patient expresses a target, I would consider right away this treatment.
Yeah. So as I mentioned, of course, obviously Saniru is from Mexico, and he's asking also real world challenges for clinicians in low and middle income countries, lack of availability of mirvetuximab. What should they look at when this agent is available? Like, who are the right patients? When is the right timing to treat these patients when you don't have mirvetuximab widely available for everybody?
Again, as we discussed before, we are practicing in different parts of the world, right? So we have a different way to approach the disease. But my recommendation would be, like we're trying to do this currently at Yale University, is to test earlier than later. So to have that information available, as soon as possible, you do your debulking, and when you request the standard type of immunohistochemistry testing, you add the folic acid receptor expression so that you know if that patient is already a potential candidate for the mirvetuximab treatment later on when she failed the aromatase inhibitor or the MEK inhibitor. That would be my recommendation because, again, we know that the majority of these patients are diagnosed with advanced stage disease. They are debulked, they're treated, but eventually they die on R because of the relentless progression of this slow-growing tumor. So anything that you can do to help your patient to survive longer, of course, is welcome. And that is
Yeah. So, Alessandro, as a tradition in the podcast now, the last question is a question that was formulated by AI when AI read your paper. And the question from AI was, given that the clinical evidence rests on a single exceptional responder with complex confounders, short gut syndrome, prior MEK inhibitor, FAK inhibitor exposure, dose reductions, how can the authors distinguish true drug efficacy from unique patient biology or altered pharmacokinetics? And is it scientifically appropriate to extrapolate this to the broader low-grade ovarian cancer population?
well, artificial intelligence is smart, right? But having said that, I think that this is a case report, is a proof of principle type of report showing that we can induce we can see clinical activity in a heavily pretreated patient that had failed previously chemotherapy, aromatase inhibitor, as well as the most effective combination of MEK inhibitor and focal adhesion kinase inhibitor. This study, I think the strength of this study is that in addition of proving that a large number of low-grade serous ovarian cancer may overexpress folic acid, is the fact that having developed the patient-derived xenograft from the same patient, running parallel to the patient, we have been able to demonstrate preclinically in vivo in the animal the activity and confirm that clinically in the patient. So we know that this is real. This is a real clinical response. Now, I agree, we need more patients. We discussed it before. I told you that I have a second patient on mirvetuximab, with a prolonged stabilization of her disease, doing very well, but two are not enough. We need a clinical trial. But we need support to do a clinical trial. And when you already have a broad, as we discussed before, FDA approval for mirvetuximab in the platinum-resistant ovarian cancer recurrent population, I'm not sure that AbbVie or anybody that has new ADC targeting folic acid are interested. But again, that would be the way to go, right? To design a proper clinical trial, 30 to 50 patients, and really see if folic acid is a good target, clinically speaking, for this patient population.
Yeah, absolutely. Or potentially even a prospective registry of patients who are being treated for this disease. And really, again, thank you for your time for this discussion. As you mentioned, definitely, of course, obviously, this is a one patient report, but all of the work that was surrounding that, the rationale, the innovation, led us to choose this article for a lead article in February. So we're really very excited again to have an opportunity to discuss it as part of our journal club. And again, thank you for your innovation always and the work that you have also done, not just with folate receptor alpha, but with the TROP2 inhibitors as well. Really great contributions to the field of gynecologic oncology, and it's an honor and a pleasure to have you on the podcast. Thank you so much, Alessandro.
Thank you for having me, Pedro.